Thanks, Simon. So what I'm going to be covering this afternoon, I'm going to do 3 things, actually. So I'm going to do complete dentures to start with, and then we'll have like a 5-minute stretch, and then I'm going to do partial dentures, and then we can have a 5-minute relax, and then I'm going to do implant overdentures to finish up. And I know that sort of overlaps everything that we're talking about, but if you need to get away and go off somewhere, just do it. It's fine. It's not a problem. And because it's a really nice small group we've got here, if you've got any questions about any of the techniques that I'm showing, please just put your hand up and interrupt, shout out, and I'm very happy to answer those questions. If there's like too many, I will just say, look, we need to carry on now. But I just want you to feel really like it's a seminar rather than just me lecturing. Okay, so that's cool. Lovely. So here we've got Bert here, and I'm going to take he's got caries, he's got periodontal disease. I'm going to take these teeth out, I'm going to extract them. And I'm going to fit a full upper denture and an immediate full lower denture for him. And when I take the Optiguard off, this is the level of suction that I had with this, and I hope the sound's on because it's really important. So I'm just going to take it out, and there's no implants on that, and that was the suction that I got with this complete lower. And I want to show you how I did that. But I got him back a week later. This is Bert's 1 week later, and I've got a Lacron here. So he's just bitten together and opened a little bit, and then I've got my Lacron carver, and I'm pushing firmly on that denture, and you can see it's not moving, and he's really helping me. He's really helping me with that with his tongue. You know, you can see that he's just resisting that push, but it's like pushing against like a solid object, like a brick. It feels nice and solid. And the secret is very much the shape of the denture, this periphery, and the way that the soft tissues all envelop the denture. And one of the secrets to this is, it's really important, is just up here. Can you see that? There's a little bit of acrylic, and that covers the retromolar pad completely. Really important part of the design. So, and then these are Bert's dentures in place. These are Shotlander Enigma Life teeth that we've characterised with some composite too. And if you look really closely at this, and I can just talk about that now, how to characterise, because I've asked, quite a few people have asked me questions about this. So if you look at Bert's teeth here, can you see we've got little cracks that we've put in the incisal edge there? So that's like a wear facet, but then we just, if you can see there's a little white line that just extends down into that. So from that little crack point there, it's like propagates this line, and that makes it look really realistic. If we just put a little groove and then follow that line up there. And the way that Rowan does this is, the Enigma Life teeth have got a lovely texture to them, but that is like as if the teeth erupted, you know, as a teenager. And Rowan just sands and smooths off that, you know, polished surface, so it's smooth. And then he gets a blade, a brand new scalpel, and then cuts it into the tooth, and it actually makes a little tiny groove. And then he gets a little bit of composite, runny composite, and in this case, it's white. Rubs it in, and it looks like a white line. And if we want a brown line, it just puts in brown composite and light cures it, and that's job done with it. It's really, and it just adds a level of detail that's really, really good. So I'll talk about, and remind me if I forget, I want to show you how he does the lower incisors. There's some better pictures for later on, you know, for putting the wear in. So, okay. So that's the arrangement there. So actually, if you want to look at these teeth, if you don't use them, Jim's here who supplies them for Australia, and he's on stand 12. You can actually go and have a good look at them. They are beautiful looking teeth. this is what I love doing, and this is what I go to work for, is to take someone from this to this. You know, Bert with his dentures in. And in order to do that, I must have a reference to actually achieve that. And what I ask is the patient to bring in a photograph of themselves with their natural teeth. That helps me to copy it. And this is what Bert brought in for me here. Can you guess which one is Bert? Here. Which one? There. Yeah, that's him. That's the only flipping picture. In fact, there is another picture of him sitting on a horse. But that's the only one. So, but I really do need to have a reference to actually copy. And we looked at this and we thought, his brother's got a similar face shape to him, so why don't we use that as a reference to set the teeth up? So even on a really blurry, enlarged picture like that, we've got a load of detail that we can actually look at and copy. So we've got this incisor just stepped back there, and you know, Rowan's done that. A nice wonky lower teeth. We love that. You know, straight lower front teeth just screams out denture. And if we actually just imbricate them a little bit, it just breaks it up and it looks great. So I used to really hate dentures though, and this is like an example of a patient I used to treat about 20 years ago. This is a common problem.
Blow it out.
I used to find it really difficult. And actually, I think what we do in removable pros is probably the most difficult part of dentistry, you know, to achieve a really happy patient in terms of function and aesthetics. You know, those two things. It's really difficult. It's a challenge. And actually, 7 years into post-qualification, because I qualified in '93, and at dental school, I'd only made 2 sets of complete dentures during my undergraduate training and 5 partials. I used to hate it, making them, because it was so unpredictable. Patients would just want to have the money back. We'd have arguments, and it was really, I just couldn't stand it. And so I just felt inadequately trained, you know, to actually do what I was meant to do. You're meant to be a flipping dentist and you can't make dentures. So seriously, I was almost giving up. And but I actually got in touch with him, Fraser, Professor McCord, who ran a master's programme in prosthodontics at Manchester, and I told him about my problems, and he said, look, come on the course. So I saved up enough money to do the course and not work for a year, moved back in with mum and dad, and then I did this master's programme, and it was the best thing that I ever did. It was terrific. And he had a great love of dentures, and it's actually why I'm here today, is because of him. And he was a really strict guy, and this is what he said about my work 2 weeks in. Seriously. No joke. And but basically, I was arrogant, and I thought I knew what I was doing, and I didn't. And I had to be told, and it really worked anyway. So these are the 7 things that I think are really, really important in all aspects of removable pros. 7 really crucial things in order to get great looking dentures and great fitting dentures too. So first of all, I'm speaking totally to the converted here, because you're all dental technicians virtually, and having a great dental technician is dead important. And I've worked with Rowan for 20 years now, and we're actually similar ages. So we've grown together, and it's like a marriage. We've fallen out, and we've got back together, and we agree with things, and we disagree with things, and it's great. I'm not married to him, but Rowan works literally I've got the clinic, the surgery, and then through a door is the lab. And I regard that is the heart of the practice, and actually the most exciting part of the practice. I love it. I'm really fortunate having a lab there. It's great, talking technical with Rowan. And this is actually this is one of the most exciting parts, is when we have a new patient and we've taken all of the records and we've got an x-ray, we've got all the photos, so we've got the models, and we sit down and we just talk it through. And Rowan has really great ideas about this. He'll say, we need to lift the occlusal plane up here or do this and that. So it's a total dialogue in terms of, can we do this? Can I achieve this clinically? It's great. So, love that. Now, this other thing here is, it's just, if I was going to be talking to myself 20 years ago, I really wished I'd have... This book is really a new book. It's new research, but I wish that I'd read this 20 years ago. It wasn't available then, but it's awesome in terms of how to get really good at something in the sort of minimum amount of time. And Anders Ericsson is the world's leading expert in human performance and expertise. And he's looked at what makes people dead good at something, kicking a football, playing golf, piano, chess, all of these things that require a lot of, and medicine as well, brain surgery and stuff. And what he's found is, and this is very clear in his research, is that true experts have a really good mental picture of what they're trying to produce before they've actually produced it. They literally see it in 3 dimensions. So these are Bert's dentures that I just showed you, and I really want to have a really good idea of where I'm heading with them. I won't have an idea straight away of the look of the dentures, immediately, but certainly from trying onwards. But I'm talking about impression making and looking in the mouth and knowing what the shape of the impression should look like just by looking at the denture space that I've got. I really want to have a good mental picture. So, in a nutshell, if I was going to talk to me and have a dialogue with me 20 years ago to try and accelerate my learning process, because seriously, I've only over the past year or so started to feel truly comfortable with my job, and actually predictability. But if I'd have approached it differently, then it would have been quicker. So I would have said, Finn, if you want to get really good at dentures, you need to do at least 5 a month, plenty of them. And also, this is very, very important, and it's just to be really, really open to feedback, totally open to feedback from the patient, because they have some really important things that they say about what concerns they have and how the dentures feel. But secondly, Finn, be open to the technician and what they're, if I take an impression through to Rowan and he knows it's not right, he tells me and I'll do it again. Got to. And then the other thing is having a mentor. And I know a lot of you have got Dr. Arbe really as a mentor here. It's terrific. And they're the people that really we can learn from. My really close mentor over the past 10 years is John Besford, he spoke at the ADC 2 years ago. I don't know whether you heard him, any of you, but he's just a wonderful prosthodontist. And I went on his course about 10 years ago, and he showed me this case. And this was the case that really made me think, wow, that's a full denture there, complete upper and lower dentures. And he calls this prosthodontic privacy. As in, no one knows that they are false teeth. So, and I want, Matt, we were talking about characterising teeth. So let's talk about the wear on these. So what Dr. B will have done here is drilled that out with a round, like a rosehead burr, a small one, and made an undercut in it. So, and then put in a dark composite. And the composite I use is HFO, but I think you can get all different types with these dark colours like GC composites, etc. So it's like a brown stained composite, thick. Push it in, and if you've got enough undercuts in, it'll stay in, just like a filling in a tooth. As dentists put like an amalgam in, for instance, that doesn't glue to the tooth. You've got to put undercuts in to stop it falling out. It's no different with these. And we have no issues with the staining coming off or coming out. So we've been doing it for almost 10 years now. Sometimes we do see a little bit of fading of the composite, but none of the patients complain about that at all, promise. So don't worry about doing it. Get that undercut in. And what I do is actually, if I will, at the trying stage, before it's been processed and finished, I will, no, in fact, that's wrong. I'll stop. Once the denture has been processed and finished completely, before it's characterised, I'll get a Sharpie pen and put a black mark there. So we want an amalgam there. And then we want a tatty composite up there and a crack line. So I just put lines on with Sharpies, and then Rowan just puts all these different characterisation in. Only if the patient wants it. And that's a very good, important point.
What was the question?
If the patient wants it. Yeah, I don't do it. We don't foist it on people at all, because if this is a spectrum of dentures from super white Simon Cowell, do you know who I'm talking about? That flipping awful set of white tombstones. Some people want Simon Cowell, and then other people want it completely age appropriate, so no one will know that they're dentures. I love that category, but I don't try and make Simon Cowell into the super characterised variety. But certainly where I live and work, which is in the northwest of England, most of my patients want to have a bit of a halfway house. So, and then what I mean by the halfway house is wonky teeth, but clean and too light. So maybe A2, wonky, with no characterisation, but with tooth wear. With wear on the incised ledges. So that is my standard approach. But sometimes a patient will come in and say, please may I have character? And that is terrific when they do that. I love it. So, and I think the more I do that type of work, the more I attract that type of a person. You probably find that in your own practice. They've got friends, they talk, and then you sort of almost engineer your practice to that accordingly. So, but I'm quite happy to do straight white and boring if they want it. It's quite funny, really. So, yeah. It's funny, but not interesting. So, but look at that. If you met this lady here, Lucy, you do absolutely, there's no way that is a denture. It was just astounding. So, and again, I know it's really boring. Finn, this is 20 years ago, read all the books you can. That Arbe book from 2010, Quintessence. Finn, read it. And get your head in the papers and learn as much about the particular topic so you can actually take bits and evolve your own technique. So it's really good. And doing courses, which I know you do, go and watch Dr. Arbe doing it, and I know quite a lot of you have been to Japan and actually practiced with him. That's just the best way of actually perfecting these techniques, is seeing someone doing it and then try and emulate it. It's good. And this is quite a difficult one, particularly when we've got our own businesses and we're worried about finance and other stuff, and we've got so much on our mind. When we're treating that one patient, Finn, just try to focus on that one patient and stay present. And staying present every single time I treat that patient. I can't do that all the time, but this is what I try to, and that helps me to learn and improve and get better. I won't be preaching anymore. I was preaching to me, by the way, not to you then. We're going clinical now. This is the exciting bit. So, now in order to produce really lovely looking, particularly complete dentures, it's just crucial to have a lovely photograph like this, a dentate picture. This is like brilliant. And more people have these photos available. you know, and they can actually find them. So, and then this is Muriel here with a British standard denture with these little tiny teeth set on the ridge, back. It just looks wrong. And I love the transition from that to this. The only thing that's changed is these teeth. And if Rowan didn't have this as a reference, if we didn't have this as a reference, you know, we wouldn't be able to do that. You know, so the only thing that changes with her is the teeth, nothing else. Her earrings are the same, her jumper's the same. So, but it actually changes the whole of her, the way she looks, Muriel here. And what I'm trying to do is, and what Rowan and I are trying to do, very much so, is to replicate nature. So if the patient was a class 1 patient, we put them in class 1. If they're class 2, and this is like really common in Britain actually, you know, big overjet is common, class 2, division 1. And this other one that's really common as well for us is a class 2, division 2. You know, that deep overbite, the butterflied laterals is a really common look there. And then thirdly, class 3. You know, so if the jaw relationships, the skeletal relationship is like that, we put them, I want to put the teeth back where they were naturally. And what we find is that it looks great when I put them back naturally, but it also is really, I feel it's really important for function too, because the teeth have erupted from the bone up. They've been guided by the soft tissues and the tongue into these particular positions, and that's the neutral zone, the zone of minimal conflict between the musculature of the tongue and the cheeks. So the dentures are more stable as a result. So it's really, you know, I think that's dead important. So in order to actually recreate that natural look, I have to try to visualize the patient. So here we've got Julie. Julie's got an upper rim in place here, a wax rim. And I'm using this here. That's a photograph of Julie with her natural dentition. She's at the age of 12. And I have to try to imagine what Julie looks like if she had her natural teeth now, and try and get a mental picture of her with her natural teeth by carving that rim in a set way, a certain way. And it's just a very simple order that I do. So number 1, I carve the lip support first. Number 2, the incisal plane second, with reference to the photo, very much so. Thirdly, trim the occlusal plane parallel to the ala tragus. Because if we all dried our heads, took our mandibles off and put our heads on the bench, then our occlusal plane will be within like literally a degree of the Camper's plane, that ala tragus. So it's anatomically correct, and it makes the dentures look terrific if we trim the occlusal plane properly using a Fox's bite plane. And that helps to produce that lovely curve following the lower lip. So that's 3. Number 2 is incisal plane. Number 1 is lip support. I actually amalgamate lip support and incisal plane together. I do those just at the same time. So I'll quickly trim it to approximately the right length incisally, and then I'll work on the lip support. But seriously, if you have an assistant working with you, like Claire's worked with me for 12 years, she's got a great eye for knowing when the patient's starting to look right as well. And it's a total constant dialogue between Claire and I at this point. And interestingly, I don't get the patient to participate at all with this. They just sit there because I don't get them to look in the mirror, because if they smile, they're just going to see a lump of red wax. And it's just completely not, useful. It's really important they participate at the try-in. You know, we've got the teeth on. So we're looking at that there. So it's those 5 things: lip support, incisal plane, occlusal plane, buccal corridor. Trim that according to the dentate picture. If the patient's wanting to have a similar dentition to how they used to be, if they want to have wall-to-wall Simon Cowell, big American smile type thing, then we just leave the buccal corridors there. Simple. And then fifth centre line, carve that on. I don't bother about smile line or carving that on there, because I do a 2-size calculation, which I'll show you later in the partial denture section, how to calculate the correct size of tooth. It's a really neat little formula. So, there we've got Julie. Please just ask questions. It's fine. There's no hassle. So, once I've carved it and got where I want to be, and Claire and I are happy, and often if I'm a little bit doubtful, Rowan will come through and have a look as well, so we get 3 eyes on the patient, checking whether it's right. I photograph the patient, and I try to photograph them at the same sort of angle as the photo of them. So even if it's like slightly side on, I'll get them to be photographed at the side on position. So Rowan's got these 2 on his iPad on the bench in the lab, you know, 2 pictures, plus he's got that wax rim, which I've really carefully prescribed, and then Rowan then sets the teeth up according to this picture. And you can probably see on here we've got quite a bit of detail, even on this picture that's blown. All I do is I've got a nice camera, SLR camera, photograph the old picture, and then put it onto my TV, onto my laptop, and I can enlarge it, and we can look at it properly. Blow it up. So I Dropbox that to Rowan, and he uses this very carefully. So, and that's what he did for Julie here. So, and you can see that he's brought that central forward, this central's back a bit, and it's sort of proportionally to the right size of teeth. I'll be talking about how to calculate the right size of teeth. You know, so there's a bit of movement in there, and what we've had to do is as we've learnt this technique, we've had to be really brave with our tooth positions and actually not doing it according to the textbook. It's just like, let's do it like nature, you know, natural teeth. And often when you do a setup on the bench, you look at it and you think, flipping heck, I've really gone for it there. And then you put it in the mouth and it just disappears. It looks straight. So it's got to be really wonky on the articulator, because it sort of levels itself up in the mouth. You know, I bet if we all smiled and looked at our teeth here, we've all got really unique, characterful teeth. So why not dentures? Sorry. Right. Impression making, 4th pillar. You know, in order to make them, you know, it's absolutely crucial that dentures fit and they don't drop down and move around. They could look fantastic, but if they're bobbling about when the patient is talking, then it's just a total aesthetic failure, isn't it? So it's absolutely down to my impression making. And it's very much along the lines of Dr. Arbe, particularly for the lower. Who's been to Japan here to see Dr. Arbe? So there's 4 of us. Have you heard him speak here? Who's heard him speak? And have you seen him demonstrate as well? Yeah, good. That's great. So, anyway, I'm going to talk about the upper first and then I'll move on to the lower. This is Bert again. This is Bert with his flabby upper ridge. So, and this is like classic combination syndrome here. And his lower teeth have been, over the years, bashing on this upper full denture and resorbing the maxilla there and leaving this wobbly ridge here. So this is what we did for Bert. We've got a window tray with this flabby material here. So prior to doing this, I've done a primary impression. an overextended primary impression to enable me to produce this special tray that's got a window in, it's got a border that goes into the sulcus, and then the flabby tissue just hangs through there. Because if I make a denture to fit onto that, conventionally I'm going to squidge that tissue, squash it, and then the denture will just want to push it down, and we need to scoop out loads of relief on that. So in order to get around that, particularly for really wobbly ones, rather than just putting tin foil on the model and putting a spacer, I do a window. And border mould here, buccally. So this is Greenstick. This is a close-fitting special tray, ready for zinc oxide eugenol on there. So Greenstick goes into the mouth, and I do various movements, which I'll show you when I do the zinc oxide, because it's just the same movements when I do the zinc oxide. So here we go. We've got Bert's here in the mouth, and I push that up right onto the saddle, and then push it firmly. And CDTs in the UK say it takes time to learn how much pressure to put on for impressions. And I say just go for it. You've got to really push it down so it's fully seated, and then you can then border mould, really go for it. So it's waggle the jaw, open really wide, and then I hold it firmly with my finger and get Bert to suck my finger. So it just contracts the modiolus just here, and that just helps with that suction effect. So it's basically what I'm trying to do is just essentially do the impression with the patient doing all the functional movements that they would do during their everyday life. So it's not going to dislodge, but maintain a seal as best as possible. So I take this out of the mouth, and then where we've got the little bit untidy edges, I just use a blade just to trim this up. And feel free to photograph anything. If you want to video the videos, go for it, it's not a problem. So that's open there. And then I put this back into the mouth. So I've got my finger on the tray very firmly, pushing it in place. So it's not moving, it's really intimately touching the tissue. And then here I have a very light-bodied silicone impression material with a fine tip on. The fine tip's really important, so I'm beading it around the border of the tray, so we get a lovely blend between the zinc oxide and the silicone impression material, all the way around the border. And then I've got another cartridge set up on the side without the fine tip on here. And I've actually got the patients almost sitting up. The head's a little bit back. I've got a knee brake chair like this, so I can actually get in close. Just hold it in. I'm just doing it like this, kneeling down. And like we said, I could do knee pads to do, it'd be good. But holding that in place, just beading that on. And you can see how loose that was. And that's where the Flabby Ridge part just sits into that front bit there. So it's just been undisplaced like that. And if you look at my primary impression here, it's absolutely squidged that ridge. If I superimpose my definitive cast on that, look how it just relaxes. And then the denture's going to fit over that really nicely. There. And then Rowan really, really carefully copies it in the final denture there. So it's all nice, you know, and that Flabby Ridge can just sit there. Question? Yeah. What's the alternative material if you don't want to use zinc oxide? Imprigum, medium bodied, I think is terrific. Yes, I think it sounds good. I love zinc oxide though. the way it flows, it's just fantastic. But that's just my preference, you know, so yeah. Because I was talking with Simon about this just before. It's, if you like a certain material and you get good results with it, just stick with it, but use these principles, really. It just needs space to go into. And it's, most special trays are overextended, they're horrible, you know, and they just need to be cut back 2 millimetres short of the sulcus depth. That's really, yeah.
Just curious, I'm not thinking.
It's all right.
In quadrant 2, just around the 2.5 buckle area, see you put the pressure, right? Oh, sorry, I'm mixed up. 1.5.
Which side is that? One?
Just here.
Yeah.
How you've got that pressure spot there.
This here?
With the Zoe.
Yeah.
Do you ever mark that and then relieve it on the denture, or do you just leave it as is for the finish?
I'd leave it as is to finish. Okay. Yeah. So I certainly wouldn't stress at all about that.
Sorry, it's been so long since I've used Zoe. So.
Yeah. No, it's not. In fact, I don't even... The primary support area for that is here. It's a good question. I know exactly, but seriously, I wouldn't even think about it. It's like, it's absolutely the most important part is I've got a great periphery for suction. It's all about this. I don't actually care too much about that centre bit, you know, because it's the periphery that forms the suction. And then if I came to fit the denture, so say we've got the denture here, I try it in. So we digress, but it's a really important point. So I've got the new denture there. I'm going to fit it and push it up, press it firmly up. And if Bert goes, ooh, that's sore there, what I'll do is I'll put a light-bodied silicone impression material on the fitting surface, goes into the mouth, and if it poked through here, I'd just draw on there with a pencil, peel it off, and drill it back. So, good point. Because I'm not actually covering that today in the lecture, but I've covered it now, so it's good. So, Bert's lower. So how do we get this really great stability? Well, I'm going to move on to the impression for the lower now. And this is quite different, how we did this. But it is based on Dr. Arbe's teachings, which is very much full coverage of the retromolar pad. There's a Sumea sinew that goes into the retromolar pad. Avoid that. Keep it short of the buccal and lingual and the buccal and labial sulcus all the way around. And then slightly overextended on the lingual, you know, from about the 7 to the 4 area. It's in his book and it's beautifully demonstrated. But also, if you want to email me, I can send you a list of how exactly to design the special tray. So, but it's brilliant. So anyway, let's get back to Bert. So I'm going to make an immediate denture for him. So these are going to come out, these teeth at the front here, those 5 anterior teeth. And it's to get a really great primary impression, I need to have it overextended, you know, because I want to make a special tray on that. So it's like a big lump of alginate. I want to get the retromolar pad, I want to get the buccal shelf, I want the lingual shelf, I want the whole lot captured there. So, and then that allows us to make the special tray. And this is really a great technique. It's a 2-part tray for this. So this is made of, it's a self-cure, it's Ivolin material. But it can be light cure, it doesn't matter. It could be any tray maker, whatever, it's fine. It's, so Rowan puts his little handle there, a little handle there, and it's short of the width of the sulcus all the way up. It avoids the Sumea sinew. We've got it fully covered on the retromolar pad there. And Rowan will make a separate over tray over that, like that, and it just fits on. So, and I'll take it out of the mouth so you can photograph it. That's why I turn it round. So it's just literally just like a whole tray. And actually the handles all slot together as well, the over tray. So, and this enables me to actually take a lower impression without those lower front teeth getting in the way. And you know, if you visualize it, if you imagine a normal special tray with a big block of acrylic that sits over those front teeth and then extends back, that big block at the front there pushes the lip away and it prevents me from doing these movements of the E and the U and actually moulding the shape properly. So I can actually do it without those front teeth getting, the actual tray sitting over the front teeth getting in the way. So, and I put the Greenstick on just a thin earthworm, a really thin earthworm size on the inside, and then a thicker earthworm on the outside. Goes into the mouth and get the patient to perform 5 movements, which I will demonstrate on the next thing. So I put zinc oxide on the fitting surface. The tray's close fitting, by the way, this, just straight onto the model. Zinc oxide eugenol. So, for instance, if you don't want to use zinc oxide, you just use Imprigum, it'll be absolutely fine with this. Goes into the mouth. Claire uses these little retractors. Do you use those since you've been to Japan? They're flipping ace. They really are. Seriously, it's wonderful. All we have done is we've just got photographic retractors and just ground them down. So they're just little hooks. And it just, I can see what I'm doing then. And then Claire just pulls that away. So I've seated it down. Is it possible to turn up the sound on my laptop, or is it not having anything? Is it maxed out? That's fine. I'll just do it verbally. So I'll put it in, push it down. Claire takes that out. I've got my 2 fingers on that, and then I get Bert to go, woo, E, and then lick his lip. Really go for it, licking the lip, push against the lower front teeth, firm with the tongue, and then swallow. So it's those 5 movements. Now, with zinc oxide, it usually takes 2 goes. So I'll do it, those first 5 things, and do it second 5 things. But I think that the really, really important bit is the swallow. I want that floor of the mouth to come up and really mould that lingual surface of the zinc oxide. And did you notice Claire had a 3-in-1 tip and she squirted it in the mouth just before he did the swallow. So a little bit of water in just to help Bert to swallow. And it's all R-based approach, this, and we found it really does help with generating some form of suction. But I think it's really important, this suction thing, I don't think, say, as important as stability. You know, the stability that I get with these dentures is way better than what I used to get when I just extended it up, halfway up the retromolar pad. Now I go right up and over, then the whole denture stays put better, you know, by the soft tissues draping. It's like a sandbag, if you will. So, right. Impression in, it just sits on these back edges of the teeth. You know, that's it there, it's just in place. And then I just fill up that with alginate over the top, like that, and then take this out. So, and it comes out together like this, all in one. And then Rowan really skillfully replicates that in the final denture. So this is the approach here. And look, I'm not stressing about I'm not stressing about this, you know, this touching the ridge, no big deal at all. Because if it was sore when I fit it, I'll be able to know, you know, and so it's not like being back at dental hospital where you go, you know, take it again. And because it really is irrelevant, actually, I think. So, and that Rowan replicates it really, you know, beautifully in the final product, just there. I'll just make sure my volume is on max. Cool. Sorry, your question. What?
You still use that 2-tray approach when extracting those into if you're doing
No. If I was doing a partial, I would do it as a oneer because there's just too much discrepancy between the here and here to get a chrome or something like that fitted. So I'd do it in one. But I'll show you that in a minute, in part 2 of this thing. Okay, any questions about impressions, definitives, or?
What about Bert? With that amount of anterior flabby ridge that you had on the upper,
Yes.
came back into 5-10 years for a reline. Is there any techniques you involve, you don't have the benefit of the two impression systems?
Yeah, don't know really, it's a good question. So, if it's going to have a reline, to be honest, I don't think you'll need it.
I'm talking 5-10 years down the track if you return.
Yeah.
Things like that. You've got that. You see those instances of very flabby
Yeah.
ridges from time to time.
That's a good point.
It can be problematic. So
Yeah.
I know you just reline them and you generally get.
Yeah. I actually, we just don't reline dentures really very often. It's the only relines we really do. And I say, when you say never in dentistry, that's just a ridiculous word. So I will have relined dentures recently. I can't remember. The only relines that I really do are immediates. So, and that's getting them through to their definitive denture. So I don't think. So right, theoretically, though speaking, if he came in and I was going to do a reline, then I would make sure I really cut out that front bit as much as possible so he had more space around it and then just do an impression. And then Rowan would then put tin foil on the model, maybe 2 layers, which would be like a millimetre space, and then reline it then. So, because I'm not actually that bothered whether it's touching or not. It really isn't. You know, it's much more important to get that peripheral seal on the border, like I said. So that's, yeah. But actually, I would like to make him a new one in 5 years' time, please. And that's not facetious either, because I think that from a health perspective, I do think it's better. But I don't have any evidence to show. I think that, you know, because they absorb all of the stuff that we eat, and it's just from a healthy perspective, I think it's better to replace it every 5 years. So, yeah.
Another way is to cut the window out.
Yeah.
The ladle of the teeth, and basically do your reline impression and then add some extra over.
Yes.
And then flask it, and then separate the flask and cut all of that old acrylic out.
Actually, yes.
And then you just process
Great
it
idea.
with brand new colour.
Lovely. So you actually cut it out, you make a window in the flipping denture and do it like that. No, but yeah, that's a good way of actually recording it. So, yeah, that's actually, seriously, Simon, I'd probably do it like that. After talking with Rowan, he'd probably say, this is what I want you to do it. But anyway, we digress.